We actually had quite a bad stabbing this morning with retroperitoneal injuries, which we recorded, and we're going to post that in a little while. So that's why we're just running a little bit late. All right, so today we're going to discuss another ECG. What I would hope is that everybody who is on Zoom will also participate. Let me just try and get you guys, just try and get everybody in. Okay. All right, no problem. Okay, that's recording, and I hope everybody can see that. Okay, but you guys can just let me know on the chat if you can see everything properly and you can hear everything properly. Okay. All right, good. So let's start. So we're going to start with an ECG for today. Okay. So Sharon, don't stress. I'm not going to stress you all out too much. Okay. We're going to, more I'm going to be expecting the people who are on Zoom to actually answer a little bit more. Right? So let's start with today's. Let's move to the first. Right. So that's our ECG. Okay. So always, whenever we start with an ECG, we first analyze the axis. Let's see, somebody wants to say something. Okay, that's fine. Thank you very much, Doc. Appreciate that. We'll just go back one now. Where am I? Sorry. Okay, so always remember, whenever we're analyzing an ECG, first analyze axis, then we analyze rhythm, then we analyze P waves, PR interval, QRSs, QRS after every P, regular groupings of PQRS, then we analyze the rate, then we analyze each zone, all right? So we're gonna go to the big picture just now, but let's just have a look at what our history is. So our history is we have a 63-year-old man with epigastric burning, belching, diaphoresis, and lightheadedness, okay? So a patient with epigastric burning, belching, diaphoresis, and lightheadedness, okay. Anybody want to start venturing a guess as to what we should be thinking about? Or what might be the problem? Nobody yet. All right. So first, let's have a look at the axis. All right. So if we look at the axis, we've got lead 1 pointing upward, and we've got lead AVF pointing upward. All right. Even though there's a slight abnormality here. So I'm sure even you guys remember, we said when both are pointing upwards, it means we've got a normal axis. Very good. All right. Excellent. That's good. All right, then we go to the rhythm. All right, so let's look at our P waves first. Okay, can you see the arrow over there? Try to make it nice and big now. Hope it shows up okay. Just adjust this a little bit. Is that a bit clearer? That's a bit clearer, eh? Okay, sorry, my eyes are not as good as they used to. All right, so let's start. So the P wave, all right? So the P wave looks normal. Let's look at the PR interval. So we said normal is between 2 and 4. Okay. So we've got here 1, 2, 3, 4, 5, 6. So what have we got? We've got an extended PR interval. All right. Okay. Chat. Hey, yeah. Dr. Sanchez is pretty close, eh? But we'll get to it now. Not to worry. Okay. So we've got this 6, so that's about 180 milliseconds, so that's quite long. Okay, but let's look at the PR interval itself. It seems to be quite regular, even though it's long, but it's regular. All right, so this is something for those of you who are not aware that's called a first-degree heart block. All right, so that means the atrium is functioning, it's sending its signal through to the ventricle, but it's just taking a little bit longer. All right, so this can be clinically significant, or sometimes it can be clinically insignificant as well. What happens is that when you have a prolonged PR interval, it can be because of electrolyte abnormalities, it can be because of a ischemic event, it can be a congenital heart disease. There's quite a few things that can cause it. But basically what's happening is the atrium contracts, it's sending its signal down, and something's just delaying that signal along the way, all right? So it may be the way that the cell membrane is being activated. So that could be due to electrolyte abnormalities and things like that. or alternatively, it could be that there's physical damage. So we know we've got a first degree. All right, so we know it's a consistent one, so that's why we say it's a first degree heart block. And right, tell me about our QRS complexes. Are they narrow? Are they wide? Anybody's welcome to answer. You can answer on the chat, you can answer in person. I'm pretty sure we can hear you. Let me just put my volume up. Sorry. I can't hear people. Just going to come out of this for a second. Let's increase my volume. Oh, it is at 100. I wonder why it's doing that. Let us go from current slide. Okay. There we go. All right, so we can hear anybody on Zoom. If you want to unmute and you want to talk, we can hear you quite easily, all right? So we've got narrow QRS complexes, okay? So that's a good sign, at least. That's one good thing. And then what's happening is these groupings are actually quite regular, okay? They are quite regular. So that's also a good thing as well, okay? But the one thing that we notice is that we've got this first degree AV block that's quite consistent, right? So then we have to look out for a few things, like I say, ischemia, electrolyte abnormalities, things like that. Now let's go back to what our patient had. Our patient had diaphoresis. For the students, what's diaphoresis? Not dialysis, all right? Extreme sweating, all right? So your patient is not just sweating, your patient is absolutely wet, all right? Absolutely 100%, he is soaked, all right? So that's one of the signs of ischemia, okay? He's lightheaded, which means he could have low BP. So these can also be due to electrolyte abnormalities, but we're starting to look more towards it, ischemia now, okay? So the rate of this patient, let's have a look and see. So his heart is going at 1, 2, 3, 4, 5, 6, 7. 300 divided by 7 comes up to just about 40 somewhat, okay? So that's quite slow. So that's a bradycardia. Okay, so that's quite a bad bradycardia with somebody who's also, I think somebody is speaker is just on
I can't hear you,
we
sir.
can hear you. Or it's giving a bit of feedback. Can you just check?
On my phone. It's amazing.
Okay, I think they might be on another call. All right, no problem. All right, so we know we've got a bradycardia, so our heart is going very slow. We've got a patient who's diaphoretic. We've got a patient who's got a block, which means that we keep on looking towards a heart attack, ischemia, right? Because ischemia at the end of the day means that blood supply has been interrupted to a particular part of the heart. It's a nice way of saying a heart attack. I mean, that's essentially what a heart attack is, right? I know it may sound simple, but that's basically what it is. So we know we've got all of these things. Now the question is, if we are suspecting an ischemia, the question is weight. Now, one of the doctors on the chat already got it quite right, but we're going to go through it step by step, all right? So let's start first. So you guys remember the zones. The first zone we always look at is the inferior zone. It's 2, 3, and AVF. And what's the first thing that we notice over there? Particularly here. Very good. So those are ST elevations, yeah. Oh, sorry. Okay, we unmuted the mics. Sorry if you guys are struggling. I might have been just leaning a bit back. Okay. All right. So we've got these ST elevations over here. All right. So in the inferior leads. All right. Now, when patients present with epigastric pain, anytime, the chances of it being an inferior MI, or as Dr. Alvarez says, diaphragmatic, but the more common term is inferior MI, because these are looking at the inferior part, then it increases those chances once you've got epigastric pain. The one thing you guys must remember, that classic thing that you learn in medical school, left-sided chest pain, going to the jaw, going down the arm, is not actually that common. We don't get it that much. And if we do get it, we're quite surprised because it doesn't happen that often, okay? So we know we've got something going on in the inferior lead. So we don't stop now. Okay, everything's fine, we know what's going on. We've still got to look at everything else, right? So let's look at V1 and let's look at V2. What do we see there? Now this is the septum, all right? Especially here, what do we notice? This was an elevation, this is a Depression, very good, Shane. So that's an ST depression. We've got an ST depression, oh, we're in V3 and V4. What do we see? Slight ST depression. And then in leads V5 and V6, which are the lateral, we see, okay, you can argue it's a bit of a ST depression as well. And then we come across to leads 1 and AVL, which are the high lateral. And if you look at lead 1 AVL, what do you notice there? That's the normal line. What's happening here? This is going down, right? So that's an ST depression, all right? So remember, these are called reciprocal changes. I'm not sure if you guys were here when I explained what reciprocal changes were. Okay, so let's put it to you this way. So I'm sitting here and you are sitting there. Let's say both of us are looking at my hand, all right? If my hand does that, what do you see? It's moving towards you, but what do I see? Away from me, agreed. So if these leads 2, 3, and AVF are here at the bottom, and they are seeing ST elevations, it means everything on the opposite side should see ST depression. So that's called a reciprocal change. Right? So once you have reciprocal changes along with ST elevations, it increases the chances of ischemia. Okay, and we never forget about AVR on that side, although this one here is not too bad. Right? So we've said that we've got an inferior block, all right, or we've got an inferior ischemia. The one other little tidbit I just want to give you guys. Do you see the ST elevation in lead 3? All right, let's count it. It's 1, 2, 3 blocks, okay, mini blocks. And then we've got this little half a block ST elevation in lead 2, all right. When you've got an ST elevation in lead 3 that's higher than lead 2, it means that this is not just an inferior infarct or not an inferior ischemia, it's also spreading to the right-hand side. Okay, it's what they call a rule of thumb. It doesn't guarantee it, but there's a very high chance, okay, that that's what is happening over here. So we don't just have an inferior MI, we've also got a right-sided MI, okay? But don't get stressed, we're going to learn about all of this in the next upcoming slides, okay? Sorry, let me just get back, somebody on the chat. Yeah, there is somebody on the audio. If people can just check their audio, I think somebody's got their phone on or we're getting interference. Even I can get it on my side. So my apologies for that. All right, so let's get on to the next slide. All right, so we said now that we have a right-sided MI. So how do we confirm it? The way that we confirm it is by doing something called, sorry, it's not a 15-lead ECG, it's an 18-lead ECG. Okay, so you guys have done ECGs before. Normally what we do, we put V1, V2, V3, V4, V5, V6, all right? And the reason why we do that is we want to look at the left side of the heart because that's where most of the damage has happened, all right? Now in this case, we are suspecting that something may have happened on the right-hand side as well. So the only thing that we do is that we switch the leads around. And we just put them in the exact same order, but on the right side of the chest, all right? So like I said, sorry, it's not, this is an 18 lead, not a 15 lead ECG. So one day when you're working and somebody asks you to do an 18 lead ECG or 15 lead ECG, don't go running around looking for a machine that has 18 leads, all right? The machine is exactly the same. It's just where you place it, all right? So basically what we're doing by doing this is that we're trying to get a view of the right side of the heart and we're trying to see what's going on over there, okay? So sorry, I just got to reply to somebody. Okay, guys, so I hope we understand that, all right? So there are others, but for now, we'll just keep it to this, all right? So what we do also when we get an ECG tracing, I want you to notice how it's been marked. It's been marked V2R, V1R, V3R, V4R, V5R, V6R. The reason being that on the ECG paper, we'll still say V1, V2, V3, V4, V5, V6. We just write a little R next to that so that somebody looking at it understands what we did. And they realize that we are looking at the right-hand side, okay? And once we do that, what we would actually see is, let's go back to this. What we would see is that, can you see where we've got our ST depressions here? We would now see ST elevations because it's looking at the heart from the other side, okay? All right, so that's just something to remember. So when your consultant asks you for an 18 or a 15 lead ECG, now you know what to do, okay? So this is the answer for what we've got today. So we've got a sinus bradycardia, right? Sinus bradycardia, because the P waves are quite regular, with a first degree AV block, which is what we figured out, right? We've got a rate of 42 and acute inferior myocardial infarction, all right? That's not a problem. So the reason why we did the right-hand side, we wanted to exclude a right-sided MI. It doesn't mean every time ST is high in lead 3, there must be. It's just that we have to make sure, right? So we've got bradycardia, first degree block, second degree block, they are saying is common complications of acute MI, but we'll get to that. These are usually vaguely mediated, right? And respond well to atropine, as did this patient. So what does that mean, right? When it says it's vaguely mediated, what it's saying is that the vagal nerve, which is in charge of our heart, sends all its impulses to our SA node, the sinoatrial node, not to the atrioventricular node, okay? So when you have these types of blocks, let's go back one, that have these narrow QRS complexes, they actually respond well to atropine because atropine stimulates that vagal nerve. Remember, bradycardia has its own complications, and its complications are further ischemia, hypotension, you know, things like that. So you need to protect your patient, basically. That's what we're trying to say. And the reciprocal ST depressions are present in leads. So this is all what we picked up. We didn't miss out anything, okay? So I just wanted to show you guys a few things about bradycardias now, just so that you can learn about it. So there's some videos, and there's a algorithm, all right? So this is the ACLS algorithm. So let's go through it with our patient, right? So we identified a bradycardia. We must look for a cause, but we don't delay treatment, right? We establish an airway, we monitor heart rate, we establish IV access, okay? These are the possible causes, okay? Now, at the end of the day, you want to check if your patient is stable or unstable. If your patient is stable, and when we say stable, I would say most of the time that has to do with their BP. So if their BP is okay, they're responding to you, everything is all right, then the first thing that you do is give this patient atropine, okay? If atropine is not effective, then transcutaneous pacing, dopamine, epinephrine, we're going to get to all of this, all right? But how much of atropine do we give? We give 1 amp, 0.5 milligrams every 3 to 5 minutes, all right? Then you can give up to a maximum of 6. So basically, we want to see if the heart responds to this atropine or not, okay? And if the heart responds to atropine, great. Your heart rate will come up, your BP will come up, everything will be okay, and then you start the patient on an atropine infusion after that. But what happens if it doesn't come up and you're giving atropine? Say, sorry, call the family, goodbye. Have you signed your will? Can I sell you a policy? We can't do that, right? So there are other things that we can do. So that's what we're going to look at now, all right? Okay, these are just the drugs, all right? So just so that you get an idea of how we use them. So atropine causes increased rate of depolarization of the vagal nerve. That's the fancy way of saying it makes the vagal nerve work faster. Okay, so the vagal nerve supplies the sinoatrial node early. So it will only help for narrow complex bradycardias. So like our patient, the QRS complex was quite narrow. So we'd expect the atropine to actually help. Okay, now the problem is if atropine doesn't help, and a lot of us now are working in situations like Madadeni or small district hospitals and things like that, where we don't have access to pacing. We're going to look at pacing just now. But the only other thing that we have in our arsenal is adrenaline. Okay, so what we do, if we want to use adrenaline bradycardia, we take 1 M, we put it in 200 mils of crystalloid, meaning Ringer's lactate, normal saline, whatever it is, and we run it at 5 mils per hour. Okay. So the reason for that is adrenaline has what they call chronotropic, that means it increases rate, and inotropic, which means it increases force. Those are its two jobs, all right? That's what it does for the heart, okay? And we can increase this slowly up to 10 mils per hour, all right? Now, this we'll get to later on. And right now, I know some of you may look at this and wonder what the heck is Morbid's type 2 and Morbid's type 3. We'll discuss these in upcoming talks. This is something to review, okay? All right, let's go on to something. So we're going to talk about external cardiac pacing. I just hope it plays.
And bradycardia is a concern, so we direct our assistant to start an IV, so we can consider giving atropine. If the patient was unstable, such as being unconscious or pulseless.
Right, just before you continue. So in other words, now we've got a patient who's got bradycardia, who's not doing too well. We've tried atropine, we've tried everything, but we want to actually do pacing. All right, so we can do something called external cardiac pacing, and that's what this video is going to describe. All right, good.
You would start with transcutaneous pacing, but since our patient is responsive, we choose atropine first. You direct the assistant to give
I need to
0.5
park
milligrams
nicely.
of atropine rapid IV push.
You need to park
The
nicely.
assistant repeats the order and then gives the medication. After about 1 minute, we recheck the vitals and find that the respirations are still around 20, heart rate still 46 and irregular
Minding,
and
I'm
weak,
okay.
and the blood pressure has not improved. It's still 76 over 40, with the pulse ox still reading 94%. Now,
I'm so sorry, guys. Somebody is, I'm just going to go through all the participants. Somebody is, I'm just going to mute a couple of people because we're getting quite a bit of interference. Okay, sorry about that. We're going to go back to the video just now. Okay. All right, sorry, that should play much better now.
based on the vitals, it looks like the atropine was ineffective. The assistant tells you that the heart rate and the blood pressure both went down and the patient just became unconscious. Now we have an unstable bradycardia. We need to start transcutaneous pacing right away. We direct the assistant to apply the pacing pads and turn the pacer on. Protocols will dictate and vary from place to place. However, the American Heart Guidelines recommend that we start at 60 beats per minute. And as the pacer is running, we turn up the milliamps until the heart muscle is captured. In our scenario, we have a consistent capture at 70 milliamps. When we have that consistent capture, we're going to then turn the interval that our machine has up so that we should be able to turn it up 2 to 5 milliamps, just a little bit more to keep the capture. In our scenario, we turn the milliamps up to 75. Once you have consistent capture at 60 beats per minute, you can turn up the rate until the symptoms improve. This is typically between 60 to 70 beats per minute. In our scenario, we turned the rate up to 68, and then we began to see that the patient became responsive again. Upon checking the vitals, we now have respiratory rate of 16, a heart rate of 68 under capture with a transcutaneous pacemaker, and the blood pressure of 96 over 60 with a pulse ox up to 96%. Once the patient's perfusion has improved, we need to continue to monitor the patient. We need to work on improving perfusion by trying to determine the cause, the bradycardia, and treating it accordingly. Now keep in mind, transcutaneous pacing can be uncomfortable, so pain management may be something to consider while deciding to move them to the next step for.
So that's basically external cardiac pacing, right? Now, like even here at Madadane, even though we're a regional hospital, we don't have pacing pads. But if you are lucky enough to get them, that's basically what you do, right? So this is what the machine looks like when you put it on, okay? So the machine will be turned onto something called pacing mode, all right? And most machines are already set up. They already tell you, you're gonna have this many milliamps and you're gonna have it at that rate. Okay, so that's normally where most people start. Now, the thing is, the first thing you have to improve or you have to increase is actually the milliamps. The reason being that you actually have to capture the heart. That's the whole point of pacing. You are trying to take over from the heart's own electrical activity. You are trying to basically say, all right, listen, this machine is going to come in, this machine is going to take over, this machine is going to tell the heart how fast to go. And the way that you do that is by increasing this, all right? And I'm going to show you what it looks like just now, all right? Then you check the peripheral pulses. And you, of course, then you can increase your rate as well, like they were describing. And then you check peripheral pulses. You want to make sure that what you are seeing is not just an electrical cap. In other words, it's not just that the machine is working, it's that it's physically working as well. So if the machine is saying that the rate is 70, you should have a 70 beats per minute. It's no use it's showing everything correctly, but when you physically put your hand on a pulse, you've still got a pulse of 40. It means you haven't won, okay? So, and basically you increase the rate until symptoms are relieved. Your patient wakes up, the BP improves, the patient feels a whole lot better, okay? So that's more or less what it is. All right, so this is what we mean by electrical capture, okay? So this is a bradycardia, right? Before we try doing anything. So every time the machine now tries, it will essentially put in a spike. a literal electrical spike that we don't normally see otherwise. Okay, so that's what will happen. But while your QRS complex is narrow like what it is here, it means that you haven't captured the heart yet. Okay, then as you start capturing the heart, you start getting these wide QRS complex. All right, the reason being because you're bypassing the normal channels. All right, then you start getting this picture that actually comes up over here. Okay, so basically the machine is now the pacemaker for the heart. Your heart is no longer its own pacemaker. So that's what you are doing, right? And the thing is, if you start already with a very wide, slow QRS complex, in other words, it's already looking like this, what will happen is as you actually capture the heart, it starts becoming a bit narrower because you're starting to give input from a bit higher up, and your patient will start to improve a little bit as well. Now, bradycardia is a complex topic. It's not a small topic. So I'm just trying to give you a few practical examples in the hope that it will help. Okay. All right. Let's see. I think we've got one more. So let's say external pacing doesn't work. All right. At the end of the day, this patient is going to need a pacemaker implanted. But there's still one more trick that we've got up our sleeve, and I want you guys to see it as well. This is something you may see, if you're lucky to work in an emergency department, you'll see it relatively often. We haven't done one in the last 5 years though. So it's normally in one of the bigger centers, but at least if somebody mentions it, you should know what it is, and that's transvenous pacing. All right.
Placing a transvenous pacer is pretty much exactly like putting in a big central line in the right IJ, with the only difference being that we're putting in a single lumen, big old cordis line in the right IJ instead of, say, a triple lumen that you may more typically use. And then through that single lumen, we're going to put in a pacing wire that's going to go all the way down to the right ventricle where it's going to pace the heart. So you got this. You can totally do this. Now we want to use either the right IJ or the left subclavian as the preferred sites because they're the closest to get to the heart, but also check this out. That curvature of the wire, we're going to use that to our advantage. So if you go through the right IJ, it's going to curve towards the heart. And if you're coming across the left subclavian, again, it's curving towards the heart. If you can, use the right IJ instead of the left subclavian so we can use that for the permanent pacemaker. Now, the only hard part about this procedure is remembering what gets connected to what are the settings that you're going to put on the pacer generator, and the pattern on the cardiac monitor that we're going to look for to know that we are in the right ventricle for sure. But don't worry, we got your back on all those things. So let's start by looking at a quick schematic overview of what those connections should look like when you're all set up.
From the right ventricle, the pacing wire comes out the SVC and through the right IJ, where you placed it. You have a sterile sleeve over the top of the sterile pacing wire. This syringe inflates and deflates the balloon, and then through adapter pins, it plugs into the connecting cable, which goes into the pacing generator.
So once you consent your patient, and we already had an informed discussion, you're going to sterilely prep and drape your patient, and then you're going to put in that right IJ line. I'm just going to assume y'all know how to do that part, so let's jump ahead. Once you got your cordis in the IJ, now you can remove the wire and the dilator. You can do this all in one motion. Plug the connecting cable into the pacing generator. This is typically sterile. This is not. So you want to have a non-sterile assistant help you with this. Ours can actually be atrial or ventricularly paced, but we're putting this in the RV, so I'm going to plug this into the V. Now that the connecting cable is all set up, we're going to check the balloon on our pacing wire and make sure that works. So you're going to use this small syringe and the one with the plunger. I mean, this can't draw up any more air than what it allows, and that's a good thing because you don't want it to rupture the balloon. So we're just going to confirm that our balloon actually does inflate. And then you're going to deflate the balloon, keep the stopcock open, and now we're going to use our sterile sleeve. So the sterile sleeve direction really matters. This side is going to connect to the cordis, which means that the wire has to feed through it this way. So we're going to feed the wire through the sterile sleeve. And now we're ready to put this wire in. Now, if you have an ultrasound machine and skilled sonographer, now is a great time to recruit some help and get a subxiphoid view. That way you can watch this wire going into the RV. And remember, we're following the curvature of the wire here, so it curves into the right ventricle.
Wait, what if I don't have ultrasound?
No big deal. It's all good. You can do this by watching the cardiac monitor and looking for an injury pattern, which we're going to show you in just a second. So for now, you're going to continue inserting this wire until you get to the 20 centimeter mark, which is indicated by the 2 black lines on the wire. Now you know that the tip of your wire, and therefore the balloon, are just outside the cordis sheath. That's a good thing. We don't want to pop that balloon. Now we can connect the adapter pins to our pacing wire. And these are going to get plugged in to our connecting wire over here. And negative goes to negative, positive goes to positive. Remember, this is not sterile, so you want to have an assistant help you with this portion. We're going to set this up, have them turn on the pacing generator, and the rate on this one is set to 80. It's okay if you go slower than that, since their intrinsic rate is going to be much slower than that. We don't have to pace the atrium, we just have to pace the ventricle. So this one has options for both, but we're just pacing the ventricle. And I have the output set at 5 milliamps. You can adjust that if you want. You could go a bit higher if you want to turn it up. You can also change the sensitivity. The sensitivity here is set at 3, but if you are troubleshooting and picking up some sort of intrinsic rate, then you can turn that sensitivity down to 0. We're just going to leave it at 3 for now. Now we're going to insert the wire a little bit further so that we can float the balloon in. So we're going to push that wire down to the 30 centimeter mark, which of course is indicated by the 3 black lines on the pacing wire. Now it's at 30 centimeters, and I'm going to go ahead and inflate that balloon. And now, probably another 5 centimeters or so. And as I do this, I'm looking at the cardiac monitor, and I'm looking for that injury pattern that looks like a STEMI and lead V1. That's it right there. And you could confirm this on ultrasound if you have it.
If the wire's being pesky and just coiling up in the RA, you're going to want to back it out, rotate the wire, and re-advance it to try to direct it into the RV. And then once you've got it, remember to confirm mechanical capture with palpation of the pulse, or you can do it with pulse ox.
So I like the positioning of where this is, and now we're going to adjust the pacing generator just to turn down that output until we barely lose capture, and then turn it back up again. Okay, so I like the position. I'm getting good capture. I have confirmation on my cardiac monitor. So I'm going to deflate the balloon, and then lock this stopcock in place. And we're going to pull that sterile sleeve all the way down to the cordis, and it connects here. Now you can open up the sterile sleeve. And this actually locks when you twist this piece. It locks it in place on the pacing wire. So this is really it. You're pretty much done at this point. You're just going to secure it in place with some sutures and a sterile dressing, and you should probably call a cardiologist. I'm Dr. Jess Mason, and this is MRAP HD.
Okay, so I don't expect any of you to be able to do transvenous pacing just because you watched that video, all right? The truth is that even if I had to do transvenous pacing, my heart would be going quite fast because it is a bit of an involved procedure, okay? But at least if somebody mentions it, you should know what it is and you should know what it involves. Essentially what it is, it's a central venous line being placed into the ventricle with a little pacemaker. That's it, nothing else, all right? It's just the procedure that I wanted you guys to see as well, okay? So I think we're more or less at the end. What we're going to do though, however, we're going to have a little, oops, this is the wrong one. Let me just try, this right, let's get this. So what we're going to do, and you guys should be able to see this on Zoom as well, is just to make sure that our CPD points, for those who are getting CPD points, are okay. We are going to have a little quiz, nothing hectic, all right? So we'll ask the questions, and it's completely anonymous, so don't worry, everybody can go for it. Let's have a look and see. So let's start. So you guys can answer on Zoom as well. I'd like you guys to answer, please, just so that we have some record that you guys are paying attention. All right, so let's look at the first question. So if we say the electrical axis is normal in this patient, does it mean everything else is normal as well? And or does it mean that it does not stop you from continuing your analysis of the ECG? What do you guys think? Okay, does not stop you, isn't it? Okay, so I see nobody's voting on Zoom. All right, no problem. But I was hoping somebody would try. I'm not sure how it. I'm actually trying it out for the first time. I hope you guys will answer. But or if you can, you should be able to see it though. Let me just check. Yeah, you should be able to see it. That's for sure. All right. Yeah, okay. So everybody fell asleep on Zoom. All right, no problem. All right, so let's try the second one. All right. So what do you guys think are the correct answers over here? First degree heart block. Oh, can you not see it properly over there? Please come and have a look at the PC. My apologies. Let me just see. Okay. I want to say you don't actually have to see the ECG. This is not based on the ECG. Don't worry. The guys who are on there. We're just asking general questions. All right. So don't stress. Okay. So if you have a first degree heart block, do you think it's extremely rare? No, it's actually quite significant. It's quite common, actually. Is it always clinically significant? And the answer is no, it's not always clinically significant. Basically, I'm doing the answers for you guys now, eh? All right, which is not, yeah, you know, yes, it may be a symptom of ischemia, all right? And it excludes electrolyte anomalies, so no need for an EBG, no such thing. You still have to do an ABG, all right? So the only thing that's correct over here is that it may be the first sign of ischemia, all right? So when you have an inferior MI with ST elevation in lead 3 greater than lead 2, multiple choice, you should never do an 18-lead ECG? No, right? TNT may cause catastrophic hypotension. Now this I actually wanted to spend some time on, it can, right? But what we'll do is we're actually going to cover this in another lecture. Basically, when you have an inferior MI and you suspect that your patient may also have a right-sided MI, don't give TNT. Okay, I'd like for people to remember that. You may need up to 10 liters of crystalloid. That's actually false. You need up to about 4 or 5. And is it impossible to have a posterior extension? No, not really. You can, all right? And how is bradycardia treated? Is it treated with atropine? Yes. Is it treated with naloxone? No. Is it treated with adrenaline? Yes. Is it treated with external pacing? Yes. Is it treated with transvenous pacing? Yes. Is it treated by placing a pacemaker in the emergency department? No. You don't place pacemakers in the emergency department. Remember that, all right? Thank you for whoever answered, by the way. I really appreciate it. Okay. So when doing pad pacing, all right, so we start by using the standard values on the machine and never change. That's incorrect, all right. Start by using the standard settings and then you increase the amps. That's correct. So whoever answered, thank you. You change the rate only once the electrical capture is confirmed. That is true as well, right? And if you have electrical capture, then you definitely have physical capture. That's not correct. Okay, because you must still check if you have physical capture as well. Okay. Okay. My apologies. I'm trying. I see some of you can't see the screen. It's my first time trying it, so I'm going to try it again on the next one. Hopefully, you'll get it better. But people are managing to answer as well. All right. So at least 4 people have managed to answer, and you guys have done quite well as well. So not to worry. Okay. So you guys can go through the questions. You can answer them as well. But yeah, just remember external pacing is used. Remember, we don't use a pacemaker in the emergency department. It's very rare for us to do that. That's normally done in theater. Okay. So I think we can stop it now. We'll just show the results. Maybe we'll try it better the next time. I hope so. Let's share results. Okay. All right. So everybody answered, yeah, it does not stop you. That's 100% correct. All right. First-degree heart block is not always clinically significant. So don't think of that. It may be the first sign of ischemia. It's true. It does not exclude electrolyte abnormalities. You may still have electrolyte abnormalities. All right. When you find an inferior MI with ST elevation, you should do an 18-lead ECG. TNT may cause catastrophic hypotension. Yes, it does. Okay. There's quite a few reasons behind that, but we're running a bit late, so I won't get into it now. Very good. Everybody knows you don't give 10 liters of crystalloid under any circumstances. Okay, you will kill your patient. It's impossible. No, it is possible to have posterior extension of this as well. Bradycardia is treated by atropine, adrenaline. It is treated by external pacing, transvenous pacing, but not by a pacemaker in the emergency department. All right. And when doing pad placing, you start with the standard values and never change. That was incorrect. You start by using the standard settings, then increase the amps. That's correct. You change the rate only once electrical capture is confirmed. That is correct. And if you have electrical capture, then you definitely have physical capture. No, definitely not. Okay. So thanks for all of those who did participate in that. We'll try again on the next one on Wednesday. Hopefully it won't be as bad. Are there any questions? Or anything that anybody else would like to know? Or is everybody happy? Yes, Dr. Masilela, you have your hand up. If you have a question, you can unmute or you can put it on the chat, either one. Sorry. The CPD points are being issued at the moment. I did get some yesterday. If you haven't received them, what I'll do, I'll send you Dr. Dlamini's number and you can just confirm with her. She's one person and she's doing it for 2 departments. So she may just be running a bit late on some of them, but I'll send it to you. I'll directly message you and you can just message her and just find out how far she is with yours so that you know when it will come. Okay, I hope that will be all right. You can just give me a thumbs up if that's okay. All right. Okay, no problem. Listen, I hope everybody enjoyed it. We'll publish the recording a bit later. And yeah, thanks everybody. If there's no other questions, then we're going to end the meeting. I've also got another meeting to rush for. Okay, thanks everyone. Bye.
Thanks, doctor. Bye.